Hello, guys. When a woman gets pregnant, whether they have an underlying rheumatic condition or not, she wants to do everything in her power to give her unborn baby the fighting chance. Even a minor procedure or seemingly benign medication becomes a concern. Today's topic is rheumatic medications during pregnancy, and this is part 2 of the lecture series on the ACR guideline for management of reproductive health in RMDs. If you missed part 1, it covered birth control for patients with rheumatic or musculoskeletal disease. I'll try to leave a link at the end of the video in case you're interested. So for today's lecture, here's the overview. We're first going to cover medications not compatible with pregnancy, then medications not compatible with breastfeeding. Then we'll discuss medications that are on the go list for pregnancy and also for breastfeeding. Lastly, we'll briefly cover paternal medication use during pregnancy. When you read a lot of the ACR guidelines, you'll see that a lot of the guidelines are color-coded by the following. So dark green means something is strongly recommended for, light green means conditionally recommended for, light red means conditionally recommended against, and dark red means strongly recommended against. Sometimes if you print the paper in black and white, you won't be able to see the colors. So they have 2 plus signs for strongly recommended, 1 plus sign for conditionally recommended, 1 X for conditionally recommended against, and 2 X's for strongly recommended against. So in my talk, when I make the chart, you'll see that I have tried to follow this color coded. So when you see crimson red, it means strongly recommended against. If you see bright red, it means conditional recommended against, and so on. So let's start off with medications that are not compatible with pregnancy. So here in crimson red, you have methotrexate, Arava or leflunomide, mycophenolate mofetil and mycophenolic acid, cyclophosphamide, and thalidomide. These medications are flat out not compatible with pregnancy, so they cannot be used during preconception, during pregnancy, or the time of breastfeeding. Next, we have medications that are in bright red. That means they need to be discontinued once patient is pregnant, but during the preconception time, it is conditionally recommended for the use of the medications. So these are the following medications. So anakinra, belimumab, abatacept, tocilizumab, secukinumab, and ustekinumab. Again, these are medications that can continue during preconception, but they need to be discontinued at the time of conception or after a patient finds out that they're pregnant. Lastly, we have a table in gray. Why is it gray? Well, tofacitinib and apremilast or Otezla and baricitinib, these are medications that are small molecules that are likely to pass through the placenta. However, there's not enough data ACR guideline to make any certain recommendations. So be wary of these medications, but there's no strong data for or against the use during preconception time or during pregnancy. It is very difficult to remember all the medications, right? So to help with remembering these medications, I have come up with some acronyms. So MAMCT, Abatsu, and TAB. That's why I changed the medications leflunomide to Arava. The brand name comes first because it'll be easier to make the acronyms MAMCT, Abatsu, and TAB. So how are you going to even remember these acronyms? So I came up with a little story. It's not the best story, but hopefully it'll help you remember. So a new mom, so a new pregnant lady, goes to Connecticut to a famous sushi restaurant called Abatsu to get some katsu chicken. She gets a tab or the bill that is so big that she had to give her rheumatic medications in exchange of the food because she couldn't pay for it. So she no longer has the medications, but it's good because she shouldn't be taking those medications anyway. So again, MAMCT or MOMCT, Abatsu, and TAB. So hopefully you'll remember this page and you can differ all the medications that you should be discontinuing at the time of pregnancy. Just a couple comments that I want to make here. So the 3 medications that you need to discontinue 3 months prior to conception are number 1, methotrexate, number 2, mycophenolate mofetil or mycophenolic acid, and number 3, cyclophosphamide. It's kind of easy to remember because those are the 3 medications that people generally abbreviate with 3 letters. Also, another point is in terms of rava or leflunomide, if there's a detectable serum metabolite level, then you want to use the cholestyramine washout. For cyclophosphamide, there's a conditional recommendation that even though the medication is on the absolutely no list, at least during the time of pregnancy in the 2nd and 3rd trimester, the medication is conditionally recommended for its use if there is a life or organ-threatening disease. So that's one exception that you need to remember. Oh, excuse me for the mistake. Here, the cyclophosphamide, the medication, the arrow is pointing at mycophenolate mofetil, but obviously it's a typo. Okay, what is a BATSU-R? R stands for rituximab. Rituximab is kind of interesting. Rituximab, I put it in yellow, and I'll explain why in a second. Rituximab is, if you look at the chart, it's shaded with light green, which means it's conditionally recommended for its use during preconception and also during pregnancy. So for rituximab, there's a conditional recommendation for discontinuation at the time of conception, but also there's a conditional recommendations for its use in life or organ-threatening disease. So I kind of think of rituximab as not in the red or green, it's kind of on the fence, and yet when you mix red with the red, the color yellow comes out. So that's why I put rituximab in yellow, so you could remember that way. Here's a couple of tips after you stop the medications or once you find out the patient is pregnant. So ideally, you would observe patient off of these medications and on the new pregnancy compatible medications prior to patient's conception so that you can ensure that disease is well controlled, because that will increase the likelihood of successful pregnancy and a healthy baby. But that's not always possible, right? So in the case where there was an inadvertent exposure to the above meds, refer to MFM or genetics counseling is recommended as good practice according to the guideline. Next, let's move on to breastfeeding. So MAM-CT medications are not recommended during breastfeeding either. The methotrexate is the only medications on MAM-CT list that is conditionally recommended against. All the other medications are strongly recommended against during breastfeeding. So that's kind of easy to remember. In terms of BATSU medications, now for breastfeeding, it turns into light green. So they're conditionally recommended. They expect minimal transfer due to large molecular size. However, there is not a lot of data for this. And in the same way, for TAB medications, so tofa and Otezla and baricitinib, there's not a lot of data, but because they're small molecules, they think the medications are likely to pass into breast milk. When you look at the tables here, that's why I put BATSU in big letters and TAB in small letters, so you could remember when you are thinking about the medications. The BATSU list are large molecular size, so we're thinking that there will be minimal transfer, whereas for TAB medications, they're small, so they're more likely to pass into the placenta or the breast milk. Let me recap what we learned so far. This table here is straight from the ACR guideline, and it kind of summarizes what we went over. So you will see the MAM-CT are definitely the medications that you shouldn't be using prior to conception or during conception, with the exception of cyclophosphamide, where during 2nd and 3rd trimester, if the patient is having life-threatening or organ-threatening disease, then you could consider using the medications, or at least it's noted as medications as conditional recommended for list. TAB, unable to determine, they're small, they're more likely to transfer across the placenta and breast milk. So the decision is sort of yours, but be wary of using them. The Abatsu medications, okay to continue prior to pregnancy, but you need to discontinue at conception. And for breast milk, they think minimal transfer is expected because of the large molecular size. Okay, now let's move on to what is on the go list. This is the top of the table 3, which goes over the medications that you could use prior to conception, during pregnancy, and breastfeeding. First 2 columns are regarding pregnancy or prior to pregnancy, and the third column is breastfeeding. So I'll kind of divide it into 2 sections. Let's just briefly kind of go over the medications. So there's the conventional medications like Plaquenil, sulfasalazine, colchicine, Imirin, prednisone, cyclosporin, tacrolimus. So the calcineurin inhibitors are there, NSAIDs are there, TNF-alpha inhibitors are there, and Abatsu we already discussed previously. Let's talk about the pregnancy part first. Couple comments about prednisone. So there's a strong recommendations to taper the prednisone to the level below 20 milligrams. And there's a conditional recommendations for use of 10 milligrams or lower dose of prednisone or non-fluorinated equivalent. There's a conditional recommendations against using stress dose glucocorticoids if the patient's going to have vaginal delivery, but there's a conditional recommendation for use of stress dose glucocorticoids if the patient is going for a C-section. About NSAIDs. So NSAIDs are noted to be compatible for use during pregnancy, but it must be discontinued if patient is having difficulty conceiving. There's a strong recommendation against use of NSAIDs in the 3rd trimester because it could lead to premature closure of ductus arteriosus. Non-selective NSAIDs, like ibuprofen, is preferred over COX-2 specific NSAIDs. So those will be things like rofecoxib or celecoxib, Celebrex, Vioxx, those medications. A couple of comments about TNF inhibitors. So when discussing placental transfer for most biologic therapies, if therapies contain an Fc-IgG1 construct, the significant crossing doesn't occur until the 2nd semester. So we prefer certolizumab with the Fc chain. And if you have to use other TNF inhibitors, there's a big question of whether to continue the medications or not beyond 2nd trimester. Let me just try to read off what they're discussing in the paper because I don't want to mislead anyone. So the use of the tumor necrosis factor TNF inhibitors that include an IgG Fc construct during the 3rd trimester. So medications like infliximab, etanercept, adalimumab, golimumab results in high levels of placental transfer and significant drug levels in the neonate. A modest amount of evidence suggests that these TNF inhibitors cause no adverse effects, especially in the 1st trimester. There was extensive voting panel discussion regarding if and when these medications should be discontinued prior to delivery. The voting panel agreed that if the patient's disease is under good control, these medications may be discontinued in the 3rd trimester. While there is a paucity of safety data, continuing TNF inhibitors through delivery if the patient's disease is active can be considered, with understanding that the neonate will have significant serum levels of drug for a period of time. Another comment is, how about medications that are non-TNF but they have IgG-based molecules? These are compatible in the periconception period but should be discontinued at the time of first positive pregnancy test. Okay, rituximab. Rituximab shows up here again. Earlier we discussed Abatsu R and learned that rituximab is recommended to discontinue at conception, but for life or organ-threatening disease, its use is conditionally recommended. So think of rituximab as one that is neither green or red, that's why it was in yellow. Just to recap, rituximab is conditionally recommended to continue while a woman is trying to conceive, and also is conditionally recommended to continue during pregnancy if severe life or organ-threatening maternal disease so warrants. One side note for rituximab use in pregnancy: dosing in the second half of pregnancy puts the fetus at high risk of having minimal B cells at delivery. So that is something that you want to discuss with your patients. Okay, let's look at breastfeeding next. What medications can you use at the time of breastfeeding? So American Academy of Pediatrics recommends exclusive breastfeeding for 6 months and then continuation of breastfeeding until 1 year. But our patients, so RMD patients, have high postpartum flares, so this may not be a possibility for them. So balance is key: disease control versus risk of infant exposure through breast milk. But it is considered standard good practice to encourage our patients to breastfeed if they desire and if they're able to do so. So let's discuss about steroids, because this is one common medication that we use. So prednisone, just like at the time of pregnancy, is recommended to keep under 20 milligrams per day or equivalent non-fluorinated glucocorticoids. But if someone is using more than 20 milligrams a day, you could recommend them to discard the milk accumulated 4 hours after taking prednisone. Let me break down other medications for breastfeeding. So MCT, we said no for methotrexate, and no for rest of the medications on that list. For Abatso and Tab are in gray because there is no real recommendations, or there isn't much data to support their use or disuse. Just remember, Abatso medications they have large molecular size, so we think there may be minimal transfer, but it's not proven with a lot of data. Tab medications are small, so be careful using them during breastfeeding. Rituximab, TNF inhibitors, and NSAIDs are all okay to use during breastfeeding, but one comment about NSAIDs during breastfeeding is that ibuprofen is preferred over other NSAIDs. Okay, let's go over paternal rheumatic medications lastly, which fortunately is a lot simpler than maternal meds. And here's the table which explains which meds are to be avoided versus which can be continued. But before going over the list, there are two different situations to consider when discussing men with RMD who are planning to father a pregnancy. Number one, a man who's planning to father a pregnancy versus a man with sexual partner who is already pregnant. Those are two different situations. In the first case, you're concerned with male fertility and med associated with teratogenicity. For these men, there are strong recommendations to discontinue cyclophosphamide, and cyclophosphamide should be discontinued 3 months before attempted conception. For thalidomide, there's a conditional recommendations to discontinue 1 month prior to attempted conception. Another note, methotrexate. There's a drug label that suggests discontinuation of medication before attempted pregnancy, but according to the guideline here, quote and unquote, data shows no evidence for mutagenesis or teratogenicity, and there's a conditional recommendations to continue methotrexate. Unlike women with RMD, Cellcept and leflunomide are also on the list of medications that can be continued for men who's planning to father a child. Sulfasalazine is noted of its potential to affect sperm count and quality, but no data suggests teratogenicity, and is also on the list of medications that is conditionally recommended to continue. So how about the man with sexual partner who's already pregnant? So the question is whether a medication present in seminal fluid can transfer to the fetus through mother's vaginal mucosa and placenta. According to the guideline, there is minimal risk, and there's no reports of post-conception teratogenesis. So reassurance regarding low risk associated with his RMD treatment is warranted according to this guideline. So this chart, again, is showing what medications you could continue, which ones to avoid. It's kind of easier and simpler compared to women with RMD because there's only 2 medications that are recommended to discontinue, cyclophosphamide and thalidomide. Methotrexate, I just share what the guidelines said, that it is on the go list, which is kind of uncomfortable for me personally because I think traditionally they have recommended men stop this medication even 3 months prior to preconception. But here I'm just here to tell you today about what the ACR guideline is recommending. Okay, guys, so we cover quite a bit today. We reviewed medications to be discontinued for women with RMD prior to conception, during breastfeeding, and also we reviewed medications on the go list prior to conception, during pregnancy, and during breastfeeding. Now, some of the medications don't have any recommendations for or against due to lack of data, like the TAB medications, the tofa, Primulist, and baricitinib. So just FYI, the brand names are Geljanx, Otezla, and Olumiant. We also reviewed paternal medications briefly. Cyclophosphamide and thalidomide are the only two that need to be discontinued according to this guideline, and methotrexate, leflunomide, and Cellcept for men are on the go list, unlike women. Since this was a lot of information, I'll leave the link to the ACR guideline for your reference. I hope this lecture was helpful. Let me know if you have any questions or comments or future requests. I will see you next time. Bye-bye.